Hi, I'm Solène Clavrel from Myeloma Patients Europe, and today I will give you an introduction on minimal residual disease, or MRD. The aims of this training are to understand, in the context of myeloma, what is MRD, MRD status, and MRD sustainability, to understand how and when MRD status is assessed, to learn about what has been shown using MRD and how is MRD currently being used, and to understand what are the potential benefits and current challenges of MRD use in clinical practice. First of all, what is MRD? It stands for minimal residual disease, and it refers to the very small number of myeloma cells that are present in the bone marrow after treatment. The number of remaining cells might be so small that a patient may have no physical sign of disease nor experience any symptoms. These remaining cells often cannot be detected through traditional test or treatment response. However, they have the potential to return and cause relapse. The results of MRD assessment is either positive, meaning that myeloma cells are detected, or negative, meaning that myeloma cells are not detected. MRD negativity indicates that a patient is in a deep remission and helps measuring the effectiveness of treatment. It can also predict risk of relapse. MRD negativity has been previously used as an important aim in solid tumor and as well as in blood cancers such as leukemia, lymphoma, and now in myeloma. What does MRD sustainability mean and why is it important? When we talk about MRD, we often talk about MRD sustainability or sustain MRD. MRD negativity indicates a very deep response to treatment, and if this deep response is maintained or sustained over time with repeated MRD testing, it might suggest that patients will have longer remissions and survival. However, its full potential is still being explored in clinical trials. Researchers have found that MRD negativity might predict endpoints that are usually used in clinical trials. Examples of these endpoints are progression-free survival, the length of time a patient is in remission, and overall survival, the length of time patients live after treatment. Doctors and researchers most commonly talk about sustained MRD negativity when a patient stays MRD negative for at least 12 months. However, other durations of time have been used. Here are three examples where patient 1 did not reach MRD negativity, patient 2 did, but it was not sustained, and patient 3 MRD negativity was sustained at 12 months and later. How is response to treatment currently measured, and how does MRD differ to this? Well, in myeloma, the evaluation of treatment response is traditionally based on criteria, including the levels of M protein in the serum and urine, and the number of plasma cells in the bone marrow. M proteins are abnormal proteins or antibodies produced in excess by myeloma cells. And this traditional evaluation of MRD involves counting cells coming from a bone marrow biopsy and or bone marrow aspirates under a microscope after labeling them with specific markers, which color plasma cells among other cells. A complete response in that case would require, among other criteria, less than 5% of plasma cells in the bone marrow. The most common evaluations of MRD also rely on bone marrow sampling through biopsy or aspirates, but also on imaging. However, MRD measures are much more sensitive than these traditional measures. The number of analyzed cells is much higher with MRD testing and can detect remaining myeloma cells, which would be missed with traditional methods. In myeloma, now the aim is increasingly to achieve MRD negativity, which confers a more favorable outcome for treated myeloma patients. To improve the efficiency of disease evaluation, the International Myeloma Working Group, which establishes international guidelines for the myeloma community, including the minimal residual disease assessment as an additional response evaluation in 2016. This group now considers MRD as the deepest level of response that could be achieved. So when and how often this is measured? Well, MRD testing is mostly used in the context of clinical trials at the moment, and when and how often MRD is measured, therefore depends on the specific clinical trial. It is used to measure a patient's response to treatment, so it's usually checked after a patient has achieved a complete response to detect residual disease levels. It might also be regularly tested after this to monitor treatment response and detect early disease progression. Given the costs and the burdensome nature of bone marrow biopsy, bone marrow aspirate for patients, some trials measure the MRD status every 4 or 6 months. So if you ask me if patients have to undergo more frequent bone marrow testing in the context of MRD evaluation, I would say it's difficult to say, as the frequency of MRD testing is expected to differ in various situations. For example, in the context of a clinical trial, MRD testing might occur every few months at the beginning of the treatment and then be further apart in time. Treatment stage, history of treatment response might also play a role. The optimal time point for sequential MRD monitoring is yet to be standardized, and future data might help setting up clear guidelines. At the moment, a 12-month time interval between 2 consecutive MRD testing is often preferred, though it's known that in the relapse refractory setting, a shorter interval would be more appropriate. As researchers know more and more about MRD and what it means, intervals could be prolonged after several MRD negative assessments, and future trials will help determine best practices. So how is MRD status determined? Well, the detection of intramedullary MRD, meaning inside the bone marrow, requires patients to undergo bone marrow aspiration and or bone marrow biopsy to collect a bone marrow sample. Researchers and doctors also rely on imaging techniques to detect plasma cells outside of the bone marrow, and this is called extramedullary detection. Measuring MRD from blood samples instead of bone marrow samples is currently being looked at by researchers, but is not yet available. The main intramedullary MRD tests which are currently used are called flow cytometry, which is the most common, and a more sensitive test called next-generation sequencing. The main extramedullary methods are based on imaging techniques such as PET-CT scans or MRI. I will now focus on flow cytometry and next-generation sequencing and later speak about imaging. So what is flow cytometry? It's a laser-based technique that evaluates individual cells by checking for the presence or the absence of specific surface markers on the cell surface. In the context of myeloma, a bone marrow sample is treated with special antibodies, which are linked to fluorescent markers that stick only on the cells that have a specific protein known as an antigen on them. Cells then flow past beams of laser light in a focused fluid stream, where myeloma cells, which are not fluorescent, are detected by the laser and counted automatically. This makes a rapid analysis of tens of thousands of cells per second possible, and therefore the calculation of the number of plasma cells in a bone marrow biopsy sample without having to look at all cells under a microscope. This approach can find one cancer cell among 100 bone marrow cells. There are different kinds of flow cytometry methods, for example, multiparametric flow cytometry or MFC, but the newest version, known as next generation flow, also called NGF, for next generation flow cytometry, is more sensitive and allows the simultaneous analysis of up to 10 million cells. This technique has been already approved by the International Myeloma Working Group as a reference method. It requires a high level of expertise, and the sample must be fresh, as high quality is a requirement for the results to be reliable. Flow cytometry is very accurate, but not as sensitive as other tests such as next-generation sequencing. And next-generation sequencing is a very sensitive sequencing technique. Sequences tell scientists about the genetic information carried in particular DNA or RNA segments. It can pick up mutations and genetic abnormalities associated with myeloma from a bone marrow sample. Numbers and types of abnormal cells can be detected and compared to baseline before treatment, for example. And this approach offers the potential for increased sensitivity. It can detect one cancer cell in 1 million cells. So what is MRD testing sensitivity? Well, each MRD testing technique, as you've seen before, has different level of sensitivity for how many cells they are able to analyze and detect residual myeloma cells. The International Myeloma Working Group defined MRD negativity as no myeloma cells being detected in 100,000 cells using flow cytometry or next generation sequencing. This can also be written as MRD negativity at the level of 10 minus 5. Some tests can detect MRD negativity at the level of 10 to minus 6. This means that no myeloma cells were detected in 1 million cells. Next generation sequencing techniques are sensitive to this level. So is there a standard for how MRD is assessed? In the recent years, there has not been a standard method for MRD detection in clinical trials, making it difficult to compare the results of clinical trials looking at MRD and to understand what it means, especially for patients. So, for example, clinical trials may use different types of MRD testing techniques with different sensitivity at different time points. And MRD testing has also been assessed in more specific disease settings, such as post-transplant, than in other settings, such as relapse and refractory. To improve and standardize the way MRD is being assessed, the FDA has issued guidance to researchers on how it should be measured, and there have also been community initiatives such as those led by the International Myeloma Working Group and the European Myeloma Network, the EMN, but also the European Medicines Agency, the EMA, which has also very recently published a reflection paper on this topic to guide stakeholders that you can find in the Annex 2 of this presentation if you're interested. But what is clear today is that alignment is important to make sure we understand the meaning and benefit of MRD for patients. So how is imaging used in MRD testing? The issue with bone marrow tests is that they do not pick up myeloma cells that are outside of the bone marrow. This is also referred as extramedullary myeloma. Imaging techniques can help address this issue, in particular whole body imaging techniques such as PET-CT scans or whole MRI scans can be combined with MRD testing to understand response to treatment. There is currently no standard for this. However, clinical trials are exploring how best to utilize these approaches together. So what has been shown so far using MRD testing? The first analysis looked at the prognostic impact of MRD negativity on patient clinical outcomes. It showed reduced risk of disease progression and relapse and a better survival for MRD negative patients. These results were obtained regardless of whether a patient had high or low risk myeloma, regardless the depth of response at the time of MRD assessment, and regardless the time of MRD measurement at diagnosis, relapse, and before-after maintenance therapy initiation, for example. When compared with other prognostic factors, MRD has been shown to be superior and the most relevant predictor of clinical outcomes. So the dynamic of MRD status changes and MRD negativity sustainability are also important. Indeed, several studies show that patients with an MRD positivity, which is slowly going down, have the same prognosis as MRD negative patients. And the Pollux and Castor studies in relapse refractory myeloma patients also found that sustained MRD negativity, defined in this case as the maintenance of MRD negativity in bone marrow, confirmed for 6 or 12 months apart, is associated with reduced risk of disease progression compared with patients who obtain MRD negative status, but not MRD sustainability. So how is MRD currently being used and assessed? It's mostly being used in the context of clinical trials, it's not yet ready for widespread use in myeloma, as there are still outstanding questions on when and how to use it and what the results mean in practice. For example, if a patient is MRD positive, is it necessary to switch treatment at this point? So the main questions that MRD clinical trials are currently looking at are how can MRD be used in treatment decision making? For example, can a patient start, stop, escalate, or change treatment based on MRD positivity or negativity? Example of studies investigating those questions are the Perseus study, which is exploring stopping maintenance treatment in patients with sustained MRD negativity. The MIDA study, which is exploring whether patients need a transplant if they are MRD negative after the induction therapy. The REDA study, which is exploring different treatment choices and treatment escalation, de-escalation in transplant-eligible newly diagnosed patients with myeloma after MRD status evaluation. The MASTER study explored treatment stops after 2 negative MRD assessment, and the REMNANT study is looking at whether patients should start treatments based on MRD positivity versus disease progression after transplants. Additional question includes how does the sensitivity of MRD testing impact on its usefulness in treatment decision making? What does sustained MRD negativity mean in the long term, and how and in different disease stages, for example, in newly diagnosed myeloma versus relapsed? MRD testing is also being used to show that the incorporation of new drugs into the backbone of multi-drug combinations leads to higher and deeper rates of responses, including more patients achieving MRD negativity. It is also used to follow up on CAR T-cell response durability. Finally, given the associations of MRD status and survival outcomes, numerous ongoing clinical trials are currently considering MRD negativity as a surrogate or an additional primary endpoints. I'll come back to that later. This might mean that researchers and other stakeholders understand the efficacy of a drug more quickly, and it could be used to get treatment approved and accessible to patients faster. So where is MRD testing used in Europe? In clinical trials, MRD testing is mostly used in Western Europe, Poland, and Greece, and these countries are also the ones with the highest number of myeloma trials in general, as you can see here on the first map of this first panel. And today, a quarter of the recruiting myeloma trials are measuring MRD status. You can see them on the second panel. Some countries even reach 50 to 80% of trials. If you're interested, you can find the number of myeloma trials evaluating MRD in the Annex 1 of this presentation per country. So what does using MRD as a primary or secondary endpoint mean? A primary endpoint is something used in clinical trials of new medicines to measure whether a treatment has worked or not. This commonly measures survivals or other areas such as quality of life. In myeloma, progression-free survival, the length of remission, and overall survival, the length of time a patient lives after treatment, are used in clinical trials to assess whether a treatment improves patient outcomes and also how it compares to other treatments. But an issue with these is that they can take a long time to measure, particularly in myeloma, as patients are experiencing longer remissions and survival after effective treatment. This can make it hard for researchers to quickly understand the full benefit for patients of this drug and to make a case to regulatory and reimbursement bodies for approval. Instead of a primary endpoint, in the context of MRD, a surrogate endpoint is something that can more rapidly predict survival. If you can more rapidly predict survival, you might be able to speed up the drug development and access for patients. There's a lot of interest from researchers and pharmaceutical companies in MRD as a surrogate endpoint. And as MRD negativity is associated with lesser risk of disease progression and better survival, this means researchers could more quickly understand the impact treatments have on patients. So regulatory and reimbursement bodies also make decisions using data on survival improvements. If MRD negativity is agreed as a surrogate endpoint, it could mean regulators and reimbursement bodies make access decisions more quickly. Whilst there are important opportunities, there are still unanswered questions before MRD is accepted as a surrogate endpoint. So how much does MRD testing cost? It could be very cost effective if it allows for treatment stops and or for dose modification, and an American research group evaluated the cost effectiveness of MRD testing during maintenance treatment for patients with myeloma in the US, and they estimated the cost of MRD testing to $3,630, including specimen collection, and assuming that treatment would stop after a patient gets an MRD negative results, they determined that MRD testing saved $1,100,000 over patients' remaining lifetime. So they later suggested that MRD assessments leads to an improvement in patients' quality of life due to less overtreatment and consequently lower risk of treatments related to adverse events. Another analysis published in 2021 estimated the cost effectiveness of MRD testing with clonoSEQ, commercial MRD assessment tool powered by next generation sequencing, compared to no MRD testing for patients with myeloma on maintenance therapy in Germany. And in this case, patients were tested every 6 months. And for a time horizon of 10 years, the savings after 10 years would be estimated to 77,000 euros per patient. So what is the potential of MRD testing in the real world for patients? The use of MRD has the potential to be an important improvement and step towards a personalized approach of treatment for patients. MRD could be predictive of the expected prognosis, for example, the expected development of the disease and the time the patient may have with or without treatment. It could allow fine-tuning of the stop, pause, or continuation decisions as regards to treatment. It may no longer be necessary to wait for disease symptoms to appear. Treatment interruption or pauses could be a new way of controlling disease, which is reasonable from the perspective of managing side effects and the financial burden of healthcare systems. MRD measurement could facilitate pausing decisions as well. And finally, the use of MRD may also play a role in faster approval for recommended treatment pathways, and it could serve as a surrogate endpoint for the determination of the value of treatments. And to finish, we'll talk about the current challenges with MRD and its applicability in the real world. While the benefits of using MRD seems quite clear, there are also certain caveats and shortcomings of its use that needs to be considered. MRD testing may require repeated bone marrow aspiration or biopsy, which can impact negatively on a patient's quality of life, as well as understanding implications for clinical practice. We also need to understand the impact on quality of life. Treatment access issues might limit its use in the real world outside of clinical trials, as even if a patient is becoming MRD positive or negative, a doctor might not be able to make treatment changes. Optimal timing of MRD assessment during and after treatment is still unclear, even though there is a standardization process ongoing. There is no clear guideline for MRD use. So this is something that needs to be done. Data is still missing to allow the use of MRD status to make treatment decisions and to understand what MRD negativity means in different subgroups of myeloma patients, and certain high-risk genetic or more aggressive disease might make interpretation of MRD negativity difficult. Another point is the monitoring of the depth of response to treatment through MRD testing, which could potentially lead to the emergence of more aggressive treatment approaches. And it's important to make sure the depth of treatment results is not prioritized over quality of life, and to limit the risk of developing multiple resistance patterns already at early stages of the disease. In this case, remission periods might be longer, but any relapse might be more difficult to handle in the future. Another point is MRD negativity does not guarantee a cure, and MRD conversion does not necessarily mean lead to clinical relapse. And finally, it is unclear whether MRD is a valid endpoint for drug approval to measure treatment effectiveness as a surrogate endpoint for progression-free survival and overall survival, the two commonly used endpoints. This is mainly due to the lack of full analysis from ongoing trials and standardized MRD detection methods, as well as studies validating the utility and the predictive value of MRD as a surrogate marker. So this is the end of this introduction. If you have any question, I'd be happy to answer them. Just write me an email to clavrel@mpeurope.org or to the rest of the team at research@mpeurope.org. At the end of this presentation, you'll find the number used for the mapping of clinical trials measuring MRD in Europe, as well as the references used for this presentation. Thanks a lot for your attention, and I hope everything was clear.